Good morning, everyone, and welcome to our NDEAM 2022 National Disability Employment Awareness Month seminar webinar number 3. Today, our program is dealing with long COVID with Dr. Tresa McNeal. You know, we've been doing these now for 4 months, or 4 years, I should say. This is the third of our fourth webinar this month for NDEAM. And we have covered so far this year, or so far in the month, we have covered in our first week, we did employee retention for people with disabilities. Second week, we did assistive technologies and accommodations. This week, we're talking about long COVID. And next week, we're going to take a little bit of a different route. And we're going to be talking about entrepreneurship for people with disabilities. My name is Carl Braun. I'm the Business Services Manager for Workforce Solutions World Capital Area, and I'm your host today. We cover the 9 counties that surround Austin and provide business services to between 15,000 and 16,000 businesses every year. So without any further ado, I'm going to introduce you to Dr. Tresa McNeal. She is with the Baylor Scott White folks, and she grew up in Sanger, Texas, UNT Eagle, Texas A&M College of Medicine, and then she's with Baylor Scott was with Baylor Scott White Center Temple, residency in combined internal medicine and pediatrics, hospitalist physician, interim chair at the Department of Medicine, and interest in research about issues affecting hospital patients, value-based care, medical evaluation, education, and healthcare communication. Dr. McNeal, thank you so much for joining us today. We're really happy to have you and can't wait to hear what your presentation is about.
Thank you, Carl. I really appreciate the introduction and the opportunity to be with everyone today. I'm delighted. You might have noticed I did grow up in Sanger, Texas. During the time I was growing up, it's a town of 3,000. So for those rural communities out there, those are my people, and I appreciate everything that this team of individuals does with Workforce Solutions to try to help our citizens in Texas be employed, stay employed, and matching up people with jobs and those kinds of things. So I really appreciate the opportunity. I'm coming from much of my experience has been a combination of inpatient and outpatient experiences related to COVID. At Baylor Scott White Medical Center in Temple, we did form a COVID recovery clinic 2 years ago. It only serves patients who have primary care physicians in the Baylor Scott White Health system, because this has been kind of a learning exercise for all of us, including our team here. And we developed that clinic more as a support to primary care physicians who were trying to learn about COVID on the fly. And we're all trying to figure out, what are our patients experiencing? What can we expect? How can we best help them? And so the health system sort of funneled patients through this COVID recovery clinic so that we could have shared learnings, and they would be coming through kind of a smaller group of clinicians working with these patients, communicating with the primary care physicians, communicating with any subspecialists that would be needed to try to optimize our care. So those are my experiences, and I'll highlight some of that as we go along. Just a quick plug for Baylor Scott White Medical Center in Temple. We do have a very large integrated practice of physicians and APPs, our advanced practice professionals. And so I think we can be a great resource for those rural communities out there, especially because coming to Temple, Texas is a little bit less intimidating than some of the larger cities in Texas, and yet you're getting 5-star care, as I would put it, that you could anticipate in the larger cities. We are the #2 ranked academic medical center on the Fortune list, and this is based not on just reputation; it's actually based on outcomes. So patient outcomes, our efficiencies of care, our educational outcomes. So we feel like those are very objective measures, and would invite anyone who has further questions, for using us as a resource to see what we can help with. That's all I'll say about Baylor Scott White, but just want to move on. So some things I hope to cover today is to define the magnitude of the workforce challenges related to COVID, talk about some of the symptoms and risk factors, and then talk about interventions. And I hope as we go along, you'll recognize that this is really a snapshot in time, and that there is perpetual ongoing learning. And there are hundreds to thousands of articles out there about this topic. So we're going to hit a few highlights on some of the most recent evidence and sort of what we can suggest for you. And then also hope you'll understand it is a moving target. We've got ongoing learnings happening in the medical world related to this. So I wanted to start out the conversation with a couple of patient stories, because I feel like that helps to put in context what's really happening with individuals. So this first one is a 67-year-old female who was referred to the COVID recovery clinic. Really, I would call this person pretty healthy, a little history of asthma, allergies, osteoporosis, and COVID symptoms began in June of 2022. She had some body aches, flu-like symptoms, sleep disturbance, some diarrhea. As we know, GI symptoms can be a symptom there. And she was back at work within 2 weeks as a checker at her grocery store, but coming to the clinic because she's still having challenges with symptoms. Now, she was not requiring modifications at work, but she does feel that she's slower, that she's not as efficient, but she's definitely doing her best and wanting to keep working. Part of her challenge would be at work that she was having some occasional diarrhea and bloating. And we think of COVID as a respiratory illness worse, because that tends to be the more life-threatening issue over the past 2.5 years that we've dealt with. However, there can be significant lingering symptoms that are gastrointestinal in nature. And so this does interrupt her workday as well. And she has also modified a lot of her life activities because she feels more fatigued after several shifts. So she's spending more time in between her shifts, just recovering from them so that she can show up well rested to the next shift. The next patient we have is a younger, happens to also be female as well, who this was June of 2021. She had her first infection, then her second one in August. Symptoms were shorter for that second infection, but she's still having some fatigue and weakness. She describes herself as feeling emotional. Again, reporting diarrhea is very common in some of these longer COVID symptoms. And she does report shortness of breath, but anytime her oxygenation is measured, it's actually good, but she feels short of breath. She's got some pain in her mid-back. I would call that musculoskeletal, again, a very common symptom. And she did start back to work about a month after the second infection. She works in a elementary school kitchen, I believe. And at the time that she was seen in clinic, she was 8 weeks out from the initial infection, but these symptoms are still continuing. So how is COVID affecting the workforce? There's a recent study that y'all's request to speak was handy, because there's just ongoing information always coming out. This study is from September of 2022. And so just in the past month or so, from Stanford and MIT, and looked at health-related absences. And so you can see that nationwide, and let me just adjust something here on my screen so I can see. You can see that nationwide, if you look at excess at the health-related absences in the years preceding the pandemic, and then what we've been experiencing, this graph probably describes what many of you have been feeling as you experience workforce challenges. And you can see these spikes in absences, and particularly in January, we know that Omicron, while not causing quite as many hospitalizations, did just run through our communities and cause a ton of labor shortages. Here, this is from the same study, but also describes patients working from home in the lighter blue, those, pre and post-pandemic. So this is looking at per 1,000 workers. And so we know that pre-COVID, six out of 1,000 workers were missing about a week of work on average. But when we come to COVID times, about 10 out of 1,000 per week. And that's a significant increase, even though that feels like not a huge number. That's still 1 week out of work. And we know that following up from this study, it's a very long paper, but we know that those employees who miss about a week of work, they're 7% less likely to be working and employed a year later after they experience this. Is that all related to physical symptoms of COVID? Is that related to this was some of the workers on the higher age range who kind of said, hey, maybe it is time for me to get out of the workforce. We know we've seen some early retirements. And so I think the issue that we're seeing is that actually that 7% that's not in the workforce a year later, that's a similar number to what we would see pre-pandemic. Let's say if they were out for another reason for a week. It's just that more people in the pandemic have been out for at least a week or more. And then that affects their downstream, even if they try to keep working, they're 7% more likely to not be in the workforce a year later. This kind of shows, again, some of what I've already shown a bit in the reduction in hours, and you can see how this has definitely spiked in the coming years. And what you see with the up and down there is some of the seasonality of illness, maybe related to flu in those years preceding the pandemic. You can certainly see the spike in early 2022. So the average cost of foregone earnings over that year in which they're out for a week related to COVID is around $9,000. And 90% of this loss is persistent loss in labor supply over the next year. So nationwide, based on this paper, they estimate that 62 billion is lost each year, which is about half of the losses that we quantify from cancer or diabetes. And that related to COVID, we've had estimated losses of about 1.5 million workers nationwide. So COVID has definitely made a dent in things. So that's about COVID, but let's talk about long COVID. We know that there's a variety of statistics reported, and depending on what you read, people are going to quote anywhere from 10 to 30% of individuals who are infected with COVID will still be having symptoms at 2 months. That number becomes lower at 6 months and again at 12. And then there are those, kind of lagging few who are going to have symptoms for potentially longer. And if we think about the experiences that patients have, certainly if they were in the ICU for a prolonged period of time and they experience severe lung injury, that's a special category of patient that's probably the minority now compared to what you're seeing with those that are actually trying to be involved in the workforce. Because those patients probably are essentially what I would call a lifelong cripple from that scarring that occurred in their lung tissue. So, respiratory compromise is just they're not going to recover most likely. But for the large majority, which is what this talk is really focused on, is those patients who hospitalized or not, symptoms were more mild. They didn't require 3 months in the ICU, those types of things. So I want to make sure we have the right patient population in mind and employee population. So we know that risk factors for long COVID are not being vaccinated. So if you are more likely to get infection, you're more likely to get COVID. If you're less likely to get infected, then you're less likely to get long COVID. Also, we know increasing age, obesity, allergy symptoms, chronic obstructive pulmonary disease, or the other term that you hear, emphysema, female gender, and a history of anxiety. So what is long COVID? So definitions here that I have recorded for you are based on those reported by the CDC and the World Health Organization. So acute COVID would be that first period of illness, symptoms related to COVID illness up to 4 weeks from symptom onset. Post-COVID would be anytime after that acute illness. So symptoms or symptom clusters that develop during or after acute COVID and persist greater than 2 months. So you'll see a lot of different terms on the web, in the medical literature. And I wanted to just put here that if you see the term long COVID, post-acute sequelae of COVID, meaning like post-acute symptoms of COVID, post-acute COVID, chronic COVID, or long haulers, we're really talking about the same thing on that. And so we do know that we also, in the medical world, we can now code this as a descriptive term that the CDC recognizes. So for unspecified post-COVID symptoms. So is long COVID considered a disability? So the Department of Health and Human Services did designate long COVID as a disability under the ADA. So under Section 504, Section 1557, I know that y'all are probably more aware than me even that this exists to protect individuals with disabilities to allow for full and equal access to civic and commercial life. And it is to be considered a disability if it substantially limits either physically or mentally one or more major life activities. So we see in terms of physical and mental challenges, there are some groupings of things, and you're probably looking at this and saying, wow, that's pretty much everything. And it is. And actually, I think this particular list, I left off some of the gastrointestinal symptoms I already mentioned that patients are often reporting. But we do know there can be lung damage, heart damage, including inflammation of the heart muscle, kidney damage, neurological damage, usually manifesting as stroke, damage to the circulatory system, meaning like in your arms and legs, because of the way we know that COVID affects and can inflame the blood vessels. And so this can contribute to poor circulation. And then there can be lingering emotional illness and other mental health conditions. There's a lot of research going into sort of the inflammatory pathway. And I think ultimately someday we'll have it more nailed down that there may be certain genetic predispositions that contributed to, certain people having more serious effects of COVID. Right now, we don't have that, but we can, mention some of the themes. So symptoms include tiredness and fatigue, which is probably the most common thing. Difficulty thinking and concentrating, very common, among, I would say, all ranges of educational levels and mental levels of functioning. Shortness of breath or difficulty breathing. We know that at least 20% of patients who have had COVID are below the lower limit of normal when we have a standardized measure of what we call a 6-minute walk test. They may have headache, dizziness on standing. This is most often related to how our body regulates our heart rate. And so when you stand up, your body kind of naturally adjusts your heart rate and your blood pressure so that you don't feel lightheaded when you stand up and so that your blood goes to your brain. Patients here can have some dysregulation of feel a little bit dizzy. And that goes along as well with the fast beating or pounding heart. This usually is improving. We're not seeing lots of people requiring pacemakers related to COVID, but it is a real symptom that's pretty common in this population. They may have some chest discomfort for any number of reasons. Cough, joint or muscle pain, as you can see, is very common. Depression or anxiety, also common. Fever, they may have, that's a little less common. Loss of taste or smell is not nearly as prominent with the Omicron variant. That's been the most recent circulating variant. And then sleep difficulties. I'm actually surprised that number is not higher in the literature because that seems to be such a common symptom. So if we look at long COVID and disability, this is straight off of the link that is on this slide. I don't know if these slides go out or not, but there are some links here that are helpful. And I think one thing that I want to point out is actually at the bottom right in that second column, where it talks about the limitations that the employees experience do not need to be severe, permanent, or long-term for them to be real and need, ongoing sort of reassessment in terms of, okay, these were your modifications in your first week back of work, but let's try to have a plan to gradually increase. And if you're seeing barriers, then we'll try to, encourage you to get the right medical care that you need. So I think we should definitely think of long COVID as not something that's like one and done. We call it a disability and a person has that forever. I think there are many people, in fact, most who will recover. It does seem to take a protracted amount of time. And I think as employers and people trying to keep our citizens in the workforce, that this is not only good for their physical health, but mental health, to keep encouraging them. One thing, and I'll come back to that in a minute. One thing I want to mention as well is to think of a little bit of two buckets of problems. So on the left here, you see the lingering symptoms of an initial illness. Those are all the things I just described that we would call more in the long COVID category. I also want to point out that there is a separate, what I would call new problems related to COVID that's a little bit different. So we know that in that first 31 to 60 days after illness, that patients with COVID are more likely to experience chest pain that may be a heart attack, a pulmonary embolism, which is a clot in their lungs, or a neurological condition, which most often would be manifested as a stroke symptom. So those are kind of separate. It's like it's a new acute problem related to the inflammation of COVID that hasn't quite settled down. But kind of, I would pull that out as a separate problem from what we're talking about with the long COVID and some of these more lingering protracted symptoms. So how long can symptoms last? I think everyone would like to know this answer, and it is variable. Most symptoms are resolved within 2 to 6 months. It can last as long as 12 months. And then I think in terms of longer range effects, I would reference some of my comments at the beginning that certainly there are patients who have had more actual scarring of lung tissue. Maybe they had more involved inflammation in their brain related to a stroke or stroke recovery, right? So those are longer range effects that I think are more difficult, but for the large majority, many people are better within 2 to 12 months, depending on their physical abilities. So this is a slide straight off of the CDC website, and it came out in May. The next slide that I have does have the link for the article that backs this up. And so it is talking about 1 in 5 adults ages 18 have a health condition that might be related to a previous COVID illness. So it says might be. And I think this is where we do have to pay attention to these symptoms and think about it. The number on this slide feels a little high to me and others that I speak to who are functioning as hospitalists or primary care physicians. In the hospital, I don't really have patients coming to me to be hospitalized that their main concern or even a side concern is lingering effects from COVID necessarily. Same thing when I talk to my primary care physician colleagues. You know, they're not having a lot of patients that are coming to clinic, not quite this many, maybe 1 in 10, I don't know. So this is what's in the data recently from the CDC, but and this is what the CDC is highlighting, I would say, on a daily basis in actual working with patients. I don't feel it to this level of severity that they're mentioning. And again, some of these symptoms can be related to any number of things, not just COVID. Some of the symptoms can be related to normal aging. So I think that's where, as medical professionals, we want to pay attention. We want to get people help that they need. And we also are thinking about not everything is COVID, right? All those other things continue going. This is just, this study was based on a massive review of an electronic health record, and this is a reference to that study. So, all right. So this study, I just wanted to mention, it also came out in the past few weeks or so. They enrolled patients that were about 6 weeks out from having had COVID. They also enrolled patients who reported to their knowledge never having had COVID. And all of these patients were enrolled whether they were reporting long COVID symptoms at the time of enrollment or not. They were, the patients who were recovering from test positive COVID and at least 6 weeks out, they were compared with enrolled patients who were not aware that they had ever had COVID. And it's interesting that symptoms of post-COVID syndrome were reported in 55% of those with COVID, and still though 13% of those who never had COVID. So we also can see from this study, and I'll show you the next slide in a moment, that there are very variable levels of immunity in the unvaccinated patients who had recovered from COVID compared with the consistent level of immunity in vaccinated individuals. This study is interesting in that they did do a fair amount of lab work on these individuals, looking for evidence of persistent viral infection, evidence of persistent inflammation, autoimmunity, where we know sometimes our body can decide to turn on itself a little bit, and just altered immune function. And this study, I think, is interesting, is in one of the major medical journals. They did not see any evidence of blood test abnormalities or other diagnostic testing abnormalities that were done in this group of patients. So it was not thousands of patients, it was about 200. But it's still kind of interesting to me that they weren't seeing measurable inflammation. And we also know patients are still having symptoms. So back to the issue of immunity, just because it's from this study. You can see on the left, you had the individuals who hadn't had COVID to their knowledge, and you can see where it says control not vaccinated, they are exhibiting some level of immunity. So the vertical axis is reporting the percent inhibition of COVID spike protein. So you can see that they've got some level of immunity, probably just from being in and around the community, right? Then you had your people without COVID who were vaccinated. That level of inhibition is very high and predictable and consistent. And then you've got those who did have test positive COVID. They're now 6 weeks out. In the unvaccinated group, you can see that their level of inhibition of the antibody is very variable. In the vaccinated individuals, you can see that it's very predictable. that they developed a very solid immune response. So it's kind of a side note, but just kind of wanted to mention that. This is a study that was done here at Baylor Scott White Medical Center Temple out of the work that I mentioned earlier related to COVID recovery clinic. So we took these patients, and this is purely on their symptom reports. And these were the groupings. And one thing that we found interesting is when you look at the blue would be patients not hospitalized, the red is patients who did require hospitalization for COVID. You can still see significant reporting of symptoms in both hospitalized and non-hospitalized. I think our study matches with a lot of the other reports that are out there in terms of the most prominent symptoms being those 4 at the top. So pulmonary, shortness of breath, that's not too surprising. Musculoskeletal, very prominent in terms of just aching muscles and joints and, recovering from the illness. Neuropsychiatric, you've heard the term brain fog. I feel like this is probably one of the hardest things to define. And much of this in just experiencing these patients is related, well, it seems on a simplistic level that sleep is one of the main things that is disturbed. And I think what we often try to do is help them either through routines or medications to try to get that sleep cycle back on track. And then we start to see some clearing of the brain fog. Obviously the cardiovascular issues that I mentioned related to clots in lungs, increased risk of heart attack, but also those symptoms of like having heart palpitations. So this is based on patient reported symptoms. And I think it's important to recognize both hospitalized and non-hospitalized had symptoms that were ongoing, I should say. So what do we know about sort of a patient's what we would call functional capacity, their ability to, move in and about their home, the community with ease, their functional ability to care for themselves, those kinds of things. So one of the ways we can look at that in an objective way is through use of cardiopulmonary exercise testing. So you would think of this test as sort of like, in your mind, a stress test that we often do to determine if a person is having some evidence of like blockage in their heart arteries. But this test is not really looking for, blockage in the heart arteries necessarily. It's kind of just looking to say, when we measure your ability to tolerate exercise, how are you doing? What do things look like when we measure your oxygenation while you're exercising and we're observing you? How does your EKG look? What is your heart rate doing? What's your blood pressure doing when we're measuring it during this active state? And so we know that based on this study that we are seeing a reduced exercise capacity after long COVID when measured objectively. And we measure this in what we call METs or metabolic equivalents, but it's a range of sort of categorized activity levels. And when we look at that, the change in functioning is approximately equivalent of aging a person by 10 years as far as expected exercise tolerance. And again, this is something that can be recovered, but again, takes time, takes incremental improvement. And as I've mentioned, we're still continuing to learn about this as we go along. So while we know there's some degree of worsening functioning, we don't really have the specifics on how long does that decrease last, and can we quantify this a little bit more accurately? So what are some of the interventions? So some of these interventions are for anyone recovering from any viral illness, to be quite honest. So COVID is a viral illness, just like the common cold, like the flu. Certainly the reason it hit our world so hard was that it had a propensity to cause much more lung damage, right? Which is what resulted in all the hospitalizations and just overtasking the resources we have to serve patients in the ICUs, et cetera. So sleep hygiene is important. These are basic things that are good for all of us, right? No screen time 30 minutes before bed. Ouch, that hurts, right? Go to bed and get up at the same time every day. No caffeine afternoon. So I think these are things that are practical that even in a workplace, we can kind of encourage each other on. And even as a physician, we encourage each other sometimes like, hey, you were sending emails at midnight. That's probably not the best thing, right? And then the rule of 10. So anytime you're trying to recover from something, you gradually increase your activity by 10% every 10 days. So particularly for these patients, you want them to avoid overexerting. Their body is still recovering, particularly in months 2, 3, 4. And you want them to be able to gradually improve, but not overexert to the point of pushing themselves further than they should. Again, gradual increase in physical activity. If they're having challenges, that's where we would recommend further evaluation, testing. And then there's energy conservation strategies that can be employed. So thinking about your day, pacing the day, not planning and cramming too many activities in their day. And what does that look like in a workplace? I think that's going to be so individualized, but anything that we can do to value their contribution to the team while helping them to gradually improve and to have understanding around that so that they do feel supported and the team also feels supported in how that individual is treated, I think can go a long way. We want to continue reassuring these individuals that most people recover and do well, and we want them to continue in that journey. Certainly when anxiety is a significant factor, they may need some help with either counseling or cognitive behavioral therapy where they can work through some of those fear-inducing thoughts that they have that come on them like a ton of bricks associated with a real physical symptom. If they're having diarrhea or stomach upset, we recommend small, frequent meals. Maybe they need to have the flexibility to leave their checkout stand when needed, depending on what the rules are with that. Healthy diet, hydration, and certainly if they did have any cardiac complications, we would recommend a supervised cardiac rehabilitation program. There's also pulmonary rehabilitation programs. We also recognize those aren't available in every place. And I think there's a lot of work going on with NBSW as well as other health systems. How can we help to facilitate a supervised rehab, potentially even virtually, right? If a person has a pulse oximeter, how can we help them to gradually increase activity in a somewhat observed way with guidance in terms of exercises, maybe for physical therapy, etc. So all of those details have not been figured out yet. I do think ultimately there will be offerings related to sort of virtual rehab programs. So again, modifications depend on the symptom and the need and the type of job. These are just some that are mentioned in some of the literature, and I know y'all already know all of these, so I'm not going to read through those. Again, I think it's important to encourage them in the fact that most people will improve, and that we can reassess, right? Maybe they do require some level of modifications and are deemed disabled for a time, but that could be reassessed. Here I've collected some online resources. This top link is the University of Vermont, actually probably one of the best patient education components that I have seen out there that I liked a lot. I wish we had figured it out. I think it's helpful. And then you can just even by Googling recovery of physical activity after COVID, some of these resources pop up. I think we all recognize in our own individual families and in the families of our coworkers that COVID impacts us not just because of the individual who happens to be the employee, but also their children, their grandparents. I think COVID times have encouraged more multi-generational family support systems because people were kind of coming together, and so recognizing that this also affects our employees. And let me see how I'm doing on time. I'm right at time almost, but winter's approaching. What should we watch out for? So again, a plug here that truly vaccination does decrease the risk of long COVID. This is based on a study out of JAMA that came out this summer. And so, and I've mentioned some other studies here. I liked this chart because I think it puts it in a very measurable way, that when you look at the vaccination status or whether they've had various doses and are kind of keeping up as they go along, the percent of patients who have COVID that end up with long COVID is decreased as you go down. And answers for that would be even if they get COVID, their body has already sort of learned how to fight it, and can therefore not have to go through the initial massive inflammation stage to fight the illness. So, and then as a total side note and just a public service announcement, the flu is hitting the Southern Hemisphere and Europe pretty hard right now. I have a colleague who works at a hospital in Abu Dhabi, and she said she's never seen so many people out of work related to flu. We have it circulating in Texas. And it's early. This is way early compared to usual for Texas. It's hit our pediatric hospital here in Temple. But the flu vaccine does help. So don't delay getting that or think you'll wait till December. I think flu is coming a little sooner. And we know that it does decrease the duration of illness. There is less missed days of work and school for families and a significant reduction in the risk of hospitalization. With that, I will close and just say that I want to thank you for all that you do in the workforce solutions area. And I'm always happy to learn more and potentially be a resource to answer questions. And I think that all of you are probably passionate about your job because it's one of those places where I do think you have a vocation where your deep gladness meets the world's deep need. So you're trying to help people be employed, stay employed, which also just helps our communities to be as active and thriving as they can. So thank you for all you do. And I'm happy to take questions, Carl.
Yes, and thank you. What an amazing presentation. I learned so much that I hadn't known about COVID, long COVID, COVID-19. We do have a few questions for you. Excuse me. So Tessie's got a question. I'll read this straight out. I think I understand what she's saying. If symptoms don't have to be severe, then can one still work and collect disability?
That is a question probably outside of my realm of knowledge on the
I would think so, yeah.
disability process. I know that there can be modifications where a person has modifications and maybe they are collecting some degree of disability for a time, but that part, I'm sorry, I don't have the answer there.
Yeah, what I would recommend, Tessie, is that you get in touch with Texas Workforce Commission. That's twc.gov, twc.texas.gov, I think, and pose your question to Ask Larry. Larry is a chatbot, an artificial intelligence chatbot that learns as it goes along, and you may be able to get an answer from that. If not, then you'll be able to perhaps call in and speak to someone. What's that, Giovanni?
This is Giovanni with Vocational Rehabilitation. I also dropped into the chat information for our call center for vocational rehabilitation and an office locator. As far as if somebody receives disability, that is determined by the Social Security department. They have a disability determination services, but we would be more than glad to, if you feel that your disability is affecting your ability to do your job, please reach out to vocational rehabilitation.
Outstanding. Thanks, Giovanni. And so another question, and this was from me, actually. I was looking at a container of Lysol wipes that's been hiding under my sink since 2014. And on the label, it said it protected and killed the COVID virus 5 years before the COVID-19 virus hit. So is COVID a generic name for the virus, and the 19 is it designated for that particular strain?
So interesting. I mean, coronavirus is a very common thing. So I don't know if the label said coronavirus instead.
It was coronavirus. You're right.
Yeah. So
Yeah.
I would say, because otherwise the term COVID, the first time I ever heard that was, March of 2020, February of 20, whenever it was starting to hit. So coronavirus has been around eons, right? Probably as long as humans have existed. And it is one of the viral causes of the common cold, along with things like you may have heard of rhinovirus, enterovirus, which could sound like enteric, like GI, but actually can cause a mixture of symptoms. So enterovirus you've heard of, the flu virus, influenza. So all of those are viruses that can cause varying symptoms. Coronavirus is previously a much more mild cause of the common cold, similar to rhinovirus.
Okay, thank you for that. Yeah, it was corona. At the very beginning, we were calling it coronavirus, and then the COVID-19 seemed to take over and coronavirus kind of went away. So is SARS also related, one of those viruses that's related to the same thing? Right,
exactly. So SARS is it is a subset of coronavirus. And so some of you might remember, although it wasn't, it was more of a news splash going back to like, I don't remember the exact year, 2002, 2003-ish. If you remember, there was kind of a big worry about SARS, and it was happening, I believe in China at the time, but it became much more contained. It didn't spread as rapidly and easily as this version of SARS. So this is, when we see a lab test in the medical world, it's labeled SARS-CoV-2. So systemic acute respiratory illness, and then coronavirus 2, right? So also there's MERS, M-E-R-S. It's all similar in the same family, Middle Eastern Respiratory Syndrome. And that again, it wasn't spread as quickly from human to human, so it didn't become, as much of a challenge.
Okay, thank you for that. So let's talk briefly, without getting into the divisiveness of masks. Let's talk about masks. Some people in the workplace have to wear a mask because of coexisting conditions, or a family member that might have one, while others have had COVID 1, 2, 3, 4 times, whatever, and choose not to wear a mask any longer, feeling that they have the natural protection. And so, do you have any guidance on masks in the workplace, and any way that we can look at them in such a way that it's not such a divisive issue, and we can all just kind of work together and not use it as an excuse for a disagreement?
Yes, I think this is one of the challenging conversations over the past 2 years, right? And I think there is a time for masks, and I do think there has been a time for masks. In the community, I just have to say, a person is just accepting their own risk. And I think we're at a time when Omicron, that variant, is not causing the severe illness and disease that it was previously causing, and increased death more than we've ever seen, and overloading medical systems to be able to actually help everyone that was coming at us, right? Right now is not that time. Our level of COVID in the hospital is very low, single digits, and these patients are generally not here with terrible respiratory illness. They're there for some other likely potentially unrelated thing. We just are testing for it. So I think out in the community, those are things that people can make their own personal choice for. And I think we see a lot of people still wearing masks because maybe they have a personal health issue that they want to be extra cautious with, or a loved one. I think in the workforce, I would say this becomes a very individual decision among employers. I can see the reasons for doing it. You're probably going to have less workers missing work as flu season approaches if they're still wearing masks. Now, I think if you're doing it to keep individuals from the community and getting, maybe your customers, I should say, to keep them from getting COVID or flu, the cat's out of the bag, right? So, I don't think that's a good reason anymore. So I think that's where I do see still lots of places requiring masks, right? We do here in the hospital for direct patient encounters, but that has even been loosened in the past couple of weeks, to where if we are even moving about in the hospital, we don't have to have a mask on. When we're in a direct patient room interacting, we do have to have a mask on. So it's been loosened at the hospital level. I don't know if that helps. And I don't think you're looking for like a perfect answer, but I do think an employer has to think about, is that an employee retention issue? Potentially, it's become such a, people hate wearing them. Is it hard to get people recruited to work at your place of employment? And then is it causing increased days of lost work that could have been prevented if they had a mask on?
Sure. Yeah, and I think, we see thousands of businesses every year, and they're all in different states of preparedness or protectiveness, right? And some we see that still have the same measures in place that were instituted at the very beginning of COVID, and some have totally relaxed. And I think it's an individual business and employee decision. And certainly some businesses, I would think people are more likely like you said, in hospitals and so on, may be more likely to be infected with a virus, whether it's COVID or the flu or whatever the case may be. And that is certainly up to them. We have another one pop in here.
And then can I just say, I think as a society, I hope that we can get to the point that if people want to wear masks, we don't take that as a political stance, right? It's it's a personal choice, and we should respect that. So I think that's where I am as I watch people. They have their choices and their reasons. And even within the hospital, we see varying degrees of people assuming risk or not, depending on, maybe they've got an infant child at home or something. So.
Yeah. Another question here: can certain prescribed medications affect whether a person tests negative for COVID-19? Despite having many of the COVID-19 and long COVID symptoms, and determined by healthcare provider the symptoms were consistent with COVID-19. Is there a medication? Are there medications that can cause someone to test for COVID-19 even though they have it?
To test negative for it?
I'm sorry, negative for it.
That's okay. Yeah. So there are no medications that I'm aware of that would make them test negative for it. It can be related to the type of COVID test that was taken. So you've heard in the news words like PCR, and that is more looking at the actual genetic components of the virus, and it's the sort of gold standard. Even then, though, your specimen can be affected by how it was collected and was there an adequate sample taken, right? So that is probably the gold standard. It will stay positive the longest. Then you think about the home antigen test. So those are, most likely to be accurate. So for instance, if you're not having any symptoms and you test negative for COVID, that's helpful, but not helpful, because that test is really going to be most accurate if you are actually having symptoms, right? So if you're having symptoms and you're trying to rule out, is this COVID? You've got fever, cough, sore throat, and you test and it's not COVID, then it's likely not COVID. I would say when you test and you're not having symptoms and it's not COVID, it's harder to say that you don't have some sort of asymptomatic infection that we know does exist. So back to the question, there's no medications that cause you to test negative.
Okay. And as we roll into December, as you had mentioned, into the winter, is there any definitive way besides a test to tell whether or not you have COVID versus the flu?
Only the test. Yeah.
Just the test. Okay. All right. Well, that's all the questions I think that we have here.
Carl,
Okay.
there was one person asking how to contact me, and I dropped in my work cell and my work email into the chat. So just wanted to make sure giovanni.terencio@twc.texas.gov and 512-756-3908 if you're wanting to contact me about more information about disability.
Excellent. Thanks, Giovanni. Dr. McNeal, thanks so much.
Yeah,
really
thank
appreciate
you.
This was a very, very awesome presentation and very informative. We're getting a lot of comments to that effect. And so thank you very much for that. This is the third in our 4 NDEAM webinar series. Next week, we're going to be talking about entrepreneurship opportunities for people with disabilities. And we're going to be using some real live world examples of different businesses that are being run with people with disabilities, how successful they are. One of them, we're going to be talking about John's Crazy Socks. So there's a young man with Down syndrome that started his own company where he sells crazy looking socks, and I'm a new subscriber. Sock of the month, that's for me. So we're going to be talking about a lot of different types of businesses next week. So that will be open. They're all open for employees and employers. That one especially, I think, would be interesting for people who are looking for opportunities or looking for different businesses that they can support. And so that's going to be next Thursday, 9 a.m. That would be the 26th, Brian. I think it's the 26th. And 26th or 27th. And so we have posted the actual dates online. You can also in the Q&A area, I posted the links to be able to sign up for next week's presentation. So again, Dr. McNeal, thank you very much. Thanks to all of you who joined us this morning. It was a great presentation. And we will see you next week with our final NDEAM seminar for the month of National Disability Employment Awareness Month. Have a great week. Bye-bye.
Thank you.